Yeah.
Welcome everyone to this workshop for the Frontline Conference. I'm Jess Griffiths, Clinical Lead for BEAT, and I'm joined by Paul Robinson and Kerry Laird. Paul, would you like to introduce yourself?
Yeah, thank you. Thank you, Jess. Okay, I'm Paul Robinson. I'm a consultant psychiatrist, been working in eating disorders forever. I'm a professor of teaching at University College London, where I run the only eating disorders and clinical nutrition master's course in the world. I'm also responsible for a project called Marzipan, which stands for Management of Really Sick Patients with Anorexia Nervosa. And the aim of that is to try and help physicians, GPs, nurses, whoever, to manage the physical aspects of risk in eating disorders.
Wonderful. And we're delighted to have your wealth of experience to share with us today, Paul. Thank you. And Kerry.
Hi there, thank you, Jess. So I'm Dr. Kerry Laird. I've been a GP for over 20 years now, having prior to that just been a product development for a couple of years. And I've also got lived experience of being a carer for my daughter who's recovered from an eating disorder. I still do some GP work, but I'm also now sort of diversifying a little bit and working alongside my local children's eating disorder service, as well as doing an echo peer coach. And I'm also helping to develop the BEAT GP training, which I'm very passionate about.
Wonderful, thank you both. And I think, the reason we've gathered together to present this workshop today is we want to talk about carers' perspective, don't we, in physical health monitoring, knowing, some detail around actually what should carers know and look out for in primary healthcare and what support should they expect. So the first part of the workshop, we've got Paul giving a really great outline of some of the Marzipan guidance, as he mentioned. And then the next part of the workshop, Kerry's going to ask him a few questions about that and try and pull out some of the information and learning for us as carers. And then Kerry and I are going to talk a little bit about her lived experience as a carer, but also what it was like to come to eating disorders as a GP. We thought that experience would be really useful to highlight. And then finally, we're going to talk a little bit about the training package that we're developing for GPs. And we're very lucky that we've got Kerry involved in that and helping to write that content for us.
Hello, everyone. I'm Paul Robinson, and I'm a consultant in eating disorders. Been doing that for many years. I'm responsible for something called Marzipan, which stands for Management of Really Sick Patients with Anorexia Nervosa. We've had a consultation on the name, and people don't want, especially service users and sufferers from eating disorders, weren't that keen on it, so we've dropped the name, so it's not going to be called Marzipan anymore. But what we're doing at the moment is revising it for the second time. So it started in 2010, then there was a revision in 2014, and this is the second revision. And so a lot of what I'm going to say is based on that work. It's really for severe eating disorders. So this talk is really about the most difficult end, the most life-threatening end, I would say, of eating disorders. And I've put an alert on that. This presentation may cause anxiety. I'm sorry about that, but I'm sure you're aware, and probably many of you have experienced, the terror that can go along with a severe eating disorder, especially when people don't seem to be taking it seriously enough. So anyway, that's what this is about, and off we go. See if I can make this work. So why are eating disorders dangerous? Well, anorexia nervosa and another condition called avoidant restrictive food intake disorder which is a condition in which there's reduction in food intake, can be very severe, reduction in nutrition. Patients can really lose weight. But as opposed to anorexia nervosa, in which people mostly are conscious of their body image and are trying to reduce their weight because of that, in ARFID, they're not really conscious of body image. They're more conscious of the qualities of the food, the colors and the physical characteristics of the food. And it's that that puts them off eating. However, they both can be fatal. We don't know the death rate in ARFID. It's too recently described for that. But in anorexia nervosa, about 1 in 20 people with anorexia nervosa ends up dying of the condition. However, anorexia nervosa is not the only dangerous condition in eating disorders. Bulimia nervosa can also be extremely dangerous because of the purging, the vomiting or abuse of laxatives, which can cause, amongst other things, low potassium levels. I mention that because it's one of the most dangerous things that you can get. Even binge eating disorder, which is not usually that physically dangerous, but it is risky because it's often associated with obesity, and obesity carries a lot of physical problems, for example, diabetes. But binging can lead to choking. Anyone who's my sort of age will remember the mamas and the papas. Mama Cass is thought to have choked to death during a binge. And also binging can cause stomach damage. Fourthly, when patients are admitted to non-specialist settings, the lack of staff knowledge, because they won't have come across eating disorders that frequently, can affect their care. So that's the reason we produce this document, which is now called Guidance on Recognizing and Managing Emergencies in Eating Disorders. People have tried to make it into an acronym, but I'm slightly anti-acronym at the moment because the last one was really thrown out. So anyway, it used to be called Marzipan. Okay, so there's the current front of it. It could change. I mean, that bit could change, but I rather doubt it that it will. We've just ended the consultation. It's due to be launched in the spring. It's an all-age document. It brings together marzipan and junior marzipan. It covers all eating disorders. It has a risks assessment system with a traffic lights. So red risk, amber risk, sounds like COVID, doesn't it? And green risk. This is really to help the physicians, the clinicians, the GPs and clinicians, but I think it could well be helpful for families as well. Now, if your clinical team doesn't know about it, we have evidence that clinical teams, especially in acute hospitals, often don't know about it. It is a good idea to tactfully bring it to their attention. I'll leave it to you to decide what tactfully means. The guidance includes a summary sheet for each interested group, and that includes physicians, carers, and people with eating disorders. We've written a summary which is directed towards you. So do have a look at that and do feedback if it's been helpful or if it hasn't been helpful. So there's the contents page. I won't go through the whole thing, but what you can see is that we've been quite broad in our approach to this area. You'll be pleased to know we've also got a glossary because we use quite a lot of technical terms. And reading about risk assessment, about families. We include something like compulsory admission. I said I wouldn't talk about it, and there I am. Okay, that's the first bit. The second bit is that we have a list of appendices. We did a national survey of marzipan utilisation by professionals, and it wasn't that reassuring. You'll see in the guidance. We've got a list of stakeholder organisations and literature reviews and guidelines. Now, in the production of this review, we were helped by the people who are responsible for NICE, the National Collaboration Committee for mental health, and they're extremely helpful, and they've helped us a great deal in producing this review. And as we've included the risk checklist for emergencies. And in the supplementary documents, we've got the summary sheets I talked about. There are 13 of them at the moment. That possibly could change. People might want us to put extra ones in. And there's a big annex on type 1 diabetes and eating disorders, which is now called TIDE, which stands for type 1 diabetes and eating disorders, surprisingly. So what can go wrong? This is the anxiety-provoking bit. First of all, medical problems. First of all, diagnosis. Sometimes doctors look for other problems when the eating disorder is causing a symptom. And the problem is usually wrong, it's probably not relevant, but sometimes doctors get led on a wild goose chase after another diagnosis. For example, a patient had liver problems. I'm very used to seeing liver problems in people with anorexia because of the starvation, but the doctor suspected that she had a paracetamol overdose. They treated the paracetamol overdose, which didn't exist actually, and they delayed nutrition, and the patient got worse and worse. Secondly, feeding too fast or too slow. There's something called the refeeding syndrome, which is caused by over-rapid nutrition. And there's the underfeeding syndrome, that's our name for it, which is caused by slow or no nutrition. In fact, we think that the underfeeding syndrome is sometimes caused by clinicians being too scared of inducing the refeeding syndrome, and they end up giving the patient nothing or very little. Underestimating severity is another thing that happens in medical places. This is partly because of the nature of severe eating disorders. Even though someone is grossly malnourished, say with anorexia, they can still be extremely active. In fact, being active is part of the problem, really, because what they want to do is burn off more calories. And so these physicians see this and they say, she can't be that bad if she's running around the ward waving at people. Well, she can be, actually. So what can go wrong? Psychiatric problems. Psychiatrists love to talk to people, and if the patient's very unwell and completely out of it, they might say, well, not really much of a role for me. I think I'll go and go back to my office. And they disappear. Well, this is not a good idea, because the psychiatrist is essential to the medical team to give them advice on how to manage the problems that can occur. The patient is terrified of weight gain, and the patient may sabotage treatment by hiding food, exercising, purging, and in other words, stopping themselves getting better. And the medical team can be completely nonplussed by this and puzzled about what's going on. Sometimes one patient who was admitted to a psychiatric ward, and she failed to gain weight. Her BMI stayed very, very low. And after about 4 weeks, they said, well, we've done our best, so we send her home. And so they sent her home, and then there was a funny smell coming from her room. And in the bathroom next door to her room, they removed the side panel of the bath, and there was all the food that she should have been eating, which she'd unscrewed the panel and put the food behind it. Lastly, the medical team may not realize that when life is threatened by anorexia nervosa, they are allowed to compel treatment under the Mental Health Act. It's not something you want to do, but it's better than allowing someone to die. And so that's why the psychiatrist mustn't disappear, because they can really help that sort of discussion. So what can go wrong with the ward staff and the family? Well, first of all, the staff may be unfamiliar with eating disorders. They're used to pneumonia and heart attacks and stuff like that, gastric problems, bleeding, all those medical things that go into medical wards. Secondly, they may harbour stigma against mental illness and maybe even against eating disorders. The family may be in a state of panic, and who wouldn't be in this situation? And that may impair communication between the family and the team. The team may try and avoid you because you're bad news. And the staff may exclude the family from the process, which is a real mistake and something we've argued against strongly in our guidance. The family is not always completely innocent. They sometimes, and I do understand this, the patient says, I've got terrible constipation because, and that's because of the eating disorder, but they won't let me have any laxatives. And so you bring them in. Well, the staff are probably right that laxatives can be very dangerous in eating disorders. The patient may abuse them and do themselves really serious damage to their bowels. So if you are if you want to argue for the case, argue with the staff. Don't bring them in under the radar. Okay, so this is the key points to be aware of. First of all, eating disorder patients can be very high risk, and I'm sure you appreciate this. The adult patients are usually better treated on a specialist unit where they know what they're doing. But if they're on a medical unit or a non-specialist unit, they must have the support of a specialist, usually a psychiatrist in eating disorders. Child and adolescents are often in generic units, partly because there's so few eating disorder services for inpatient eating disorder services for children. But if they're not doing well in those services, they should consider referring them to a specialist eating disorder unit. And non-eating disorder specialists such as gastroenterologists and other physicians and surgeons and whoever's looking after the patient in the hospital must have the support of a specialist eating disorder doctor who, if they have a ward round at 7:30, which they often do, the psychiatrist has just got to get up and go to it. I've told them that, and they say, well, it's a bit early. Yeah, not early enough. Okay, so this is a bit of a busy slide, but I thought I'd show you how medical staff assess risk, and this really comes from the guidance. So first of all, the history. Doctors take a history, they examine the patient, and then they do bloods and other investigations. So that's how this is organized. So in the history, someone who's having difficulty climbing stairs, that is a high risk. Secondly, they may test the muscle power. There's a SUS test, which I'll show you in a minute, and the hand grip strength, which is also useful. And the high risk level is unable to stand up or sit up from lying flat. The BMI, which is the weight in kilograms divided by the height squared, is the way we compare people with different heights. And less than 13, or for underage, for under 16, or under 18 actually, less than 70% of median BMI is the red risk, or a very rapid fall in weight of over 1 kilogram per week. The bloods, well, the potassium level is the one that's the most dangerous. Less than 2.5 millimoles per litre is the danger level, but any reduction from normal is significant. Other things like the sodium, the liver function, all sorts of things can go wrong. I won't go through the whole of the list of blood tests, but many of them can go wrong. If they're being refed, then phosphate can go down dramatically, and magnesium. The temperature, which you have to do either a mouth temperature or rectal temperature, if it's less than 35.5 degrees, that means that the person is at high risk. And low temperature is caused by loss of insulation, or loss of the fat under the skin, which keeps you warm. And people with very low weight, either through anorexia nervosa or ARFID, don't have that. Now, the ECG, the heart rate, for example, there's the heart rate goes down. Now, this is a normal body mechanism. If you've got no energy around, you want to reduce the amount of energy the body is using, so the body reduces its own heart rate. That's okay. But if it's less than 40, that's a bit too slow, especially if the patient is awake. If the patient's asleep, it can go down a bit more than that. And any other serious finding, low blood pressure, dehydration, and psychiatric things like suicidality, the high risk would be these things which you regard as life-threatening. At the bottom, you'll see an ECG, it's a heart tracing, and on the left is someone who's admitted with anorexia nervosa. And where I put the box there, it's called the T wave, and it should be upright. And you can see it's inverted. Now that is a sign that the heart is under strain. We gave her food for a couple of days, and on the right, you see exactly the same patient, and the T waves are nice and positive and pointing upwards, which they should be. So it just shows you how quickly the heart can respond to nutrition. This is the SUS test, the sit up, squat, stand test. You lie flat and sit up. You squat down and stand up. And there's the scale, which we use clinically. I have a volunteer, also happens to be my daughter, who has done a demonstration of the different scores on that YouTube video. So some patients try and prevent what they fear most, weight gain. They resist admission, even if they're very physically ill. They're saying, look, I know you think I'm going to die. I'm not going to die. I'll be all right. I'll eat more. But sometimes the psychiatrist has to think about compulsory treatment if some of those risk factors are very severe. They falsify their weight by drinking water and wearing weights. I had one patient who managed to drink over 8 litres of water by putting the shower in her mouth and switching it on. She eventually had a fit in the street because her sodium level went down so low, and she did wake up, and she didn't have any brain damage, thank goodness. They increase their energy use by micro-exercising, which is like standing or wiggling your hands and feet. They get cold deliberately to induce shivering. They get rid of food or feed, if they're tube fed, by hiding the food or binning it. And they vomit after meals and take laxatives. And I'm sure as families you're aware of some, if not all, of these things. So what carers and families can do to help? Well, first of all, get help in time. If you're worried about the physical state, put your relative in the car and assume you got one, and take that person to the emergency department. That's the new name for accident and emergency, which is a bit confusing because it has the same initials as eating disorder. Anyway, we'll have to cope with that. So get them to medical help. If they're admitted and you're concerned that the person is not being given enough nutrition, ask the doctor if they're following guidelines, and if so, which. And if you're not happy with that, then bring in the marzipan guidelines. Avoid bringing in things such as laxatives, which I've told about. I'm sure you won't do that. Ask to see the psychiatrist advising the medical team, and you can often find out what the plan is, because speaking to physicians sometimes it can get a bit technical. You are entitled to a second opinion, but rather than get your retired uncle to come and give it, request it through the team looking after your relative, and they have to, under the NHS or even in a private setting, have to get a second opinion for you. Okay, that's it. I'm sure there'll be time for questions at some point, but thank you very much for listening.
So, Kerry, I think you're going to ask Paul a few questions now about his presentation, so I'll hand over to you.
Thank you, Jess, and thank you, Paul, very much for a fantastic presentation. Lots of very useful information, I think, both for professionals and for carers in there. I think one of the things you mentioned, obviously, is talking about changing the name marzipan. I mean, that's one of the things, I guess, we've spent a lot of time trying to get people to know about the marzipan guidelines. And are you going to change it to a name that people are equally going to remember, we hope, or what's the thoughts on that?
Yeah, this is a tricky area. It was actually the experts by experience on our group who consulted their constituency, who were not happy with the name. And also, it wasn't only ex-patients, it was also some doctors, the liaison faculty, and people who didn't like it. One reason, which actually I agree with, is it's anorexia focused, because it says it's got AN in it, which and we want to be clear that we're talking about all eating disorders. The other thing is that it's someone said it's a sort of high-end confection, which they didn't particularly like to be, felt it a little bit demeaning, and so. What we discussed it at length. I hope I'm not talking out of turn here, because we haven't actually agreed anything yet, but because the meetings are not finished. We decided ultimately, I think, anyway, so far, we've decided not to have an acronym at all, and just call it we haven't decided on a final title for it, but it'll be something like. Sort of guidance on emergencies in medical emergencies and eating disorders.
Okay, and I think it's how you just make sure that people know that's effectively the new marzipan. So I guess that's kind of my second question: is how do you make sure that people are aware of the changes to the guidelines? How do you ensure that they know where to look for them? I guess both for professionals again and for carers, because I think, as you've highlighted, sometimes it's useful for carers to know what sort of things that maybe their professionals should be doing and possibly aren't. So where would people be able to access that information and know about it, do you think?
Well, I think at least in the short term, the title will include in brackets formerly marzipan and junior marzipan.
Yeah.
So if you look for that on Google, that will come up. I think, depending on how much people use it, and I hope everyone will use it, that if you put in eating disorders and physical problems or medical problems, you should get it quite easily. And also it'll be on the website of the Royal College of Psychiatrists, freely available.
Yeah, which is, I guess I wonder whether we can then think about how we get that to GPs as well, isn't it? And possibly on the BEAT website. I guess it's it's about getting it out there in as many places as possible. And I mean, at the moment, obviously, there's an amazing Marzipan app. Will there be a new updated app as well?
Yes.
Yeah.
Yes. Yes.
I know lots of people use that.
There will, yes. There'll be a new app. It'll be all age, so it'll be a combination of junior and the old senior Marzipan, and it'll also be all eating disorders. So it'll include the physical problems that people with bulimia have, people with binge eating disorder have, and people with ARFID, avoidant restrictive food intake disorder have.
Fantastic. And I guess one of the other things I was thinking about was, how do you think, how easy or how difficult, I suppose, what will the challenges be for people to adhere to those guidelines in the kind of current climate, whereby we know people are struggling maybe to get to be seen or to get to hospital, or there is sort of quite stretched resources? Because obviously with any guidelines, it's good to have, best practice, but if people are unable to do that, what are your thoughts on that?
Yeah, well, actually, just to answer your first question about how, I mean, what we hope the guidelines will be helpful and practical, so that you're faced with someone with an eating disorder in any context, in primary care, in what's now called the emergency department, which is a bit confusing for us because it's got the same initials as eating disorder. But anyway, that's another matter. But in the emergency department, or a district nurse, or whoever is facing someone with a severe eating disorder, we want the guidance to be really helpful in assessing, how worried should they be about a pulse of 50 or a pulse of 30. How worried should they be about someone who is so weak they can't walk up the stairs, for example, things like that. So we want it to be practical and helpful. And I don't think we've tried to be quite extensive and quite comprehensive in the guidance. So it is quite big. So one thing we've done, which is going to be new for Marzipan, is that for each constituency, each group, whether it's GPs or nurses or therapists or patients, ex-patients, current patients, relatives, we've got a sheet for them giving the basic information that they need to know. And we hope that'll be really useful because it's very brief. It's only one sheet of A4. And there's, as I said, there's one for each constituency. But you will have to look into the guidance to find out the details.
But I think it sounds like if you've got those summary sheets, that's somewhere where people can start, isn't it? Because actually, right, okay, I'm thinking about sort of, I guess from a GP point of view, right, okay, where's that one sheet I can look at instead of going through the 130 pages? So I think that sounds really helpful, actually. So that's great.
Yes, and we hope, you mentioned the app. What we hope to have on the app is the new risk assessment. So you'll be able to put in the blood pressure, put in the temperature, all the things that, all the tests that you can do to check on risk. And that does include things like tendencies to self-harm, thoughts about self-harm. And it does include the degree to which someone is engaged in treatment. Are they fighting you? Are they fighting their parents? Things like that. That is also a risk factor. So you'll be able to put all those things in and have a summary of the essential risk factors. But then I think you do probably need to be a professional to assess what the meaning of those risk factors is in terms of what's the real risk. Because just because someone has a red risk, because it's a traffic light system, red, amber and green, someone has one red item doesn't necessarily mean they have to be in hospital. So you have to have someone to interpret what it means.
I guess I always think it's a bit like a jigsaw puzzle, isn't it? It's about putting those pieces of the puzzle together to get a picture. But as you say, it's a bit of interpretation then along the way. But at least if it indicates that someone's got some red risks, it's going to raise your alertness to thinking, okay, I really need to look at this properly, and probably maybe speak to someone else if I don't know what that means. I guess it's about just making sure that alertness is there. Because I think, interesting, you're talking about pulse. I mean, certainly I've been aware of some cases recently where people have sort of been to see people and, you know, maybe their blood pressure has been unrecordable or their pulse has been very low, and actually the professional hasn't quite known what to do with that. And actually that's almost just basic medicine, isn't it? But I think having that context of actually people knowing, okay, what do I do with this information and what's the next step, I think is really helpful.
You're absolutely right. And I think the trouble with eating disorders is not that it's a medical problem, it's that it's a psychiatric problem, that it's part of psychiatry. And I'm afraid psychiatry is a bit of a headlight dazzler, as it were, for many physicians. They see psychiatry and they think, oh, I know nothing about this, better call a psychiatrist. Well, if they do, that's good. But more often they send the patient home when they shouldn't. So one thing I wanted to say to carers is that, you know, if I was a carer, my son or daughter I was very worried about them with an eating disorder, and I was facing a doctor who didn't seem that worried, I would be tempted to say, look, I've had a look at this document, this Mozipan or whatever it's called document, and it says here that this is a high risk. What do you make of that? And I know some doctors might resist that, might not like it, because nobody likes people coming in waving Google at them when they come into the surgery. But I think that's one thing that carers could do. And the other thing I wanted to say was that if you're really worried about your relative, if they're collapsing and things, get them to hospital. Get them straight. Don't even call anybody. Stick them in your car, or maybe even call an ambulance and get them to hospital. Because there have been a few cases where there's been delay from that situation, and it hasn't turned out well.
I think that's a really important message, Paul, and something we've done here in Dorset is I would be giving out, you know, the marzipan guidance to carers a lot of the time and saying, just take that in and say, this is what needs to be done. Don't mince your words. Don't, you know, if they don't know about it, you know, there's too much risk at stake here. And I think that's a really helpful thing for carers to hear, is that actually we give them the resource and help them there with their knowledge around what they can do, I think.
Exactly. Yes. I mean, I used to say before you know it was all online, take the document, roll it up, and use it as a weapon to hit people on the head with. But unfortunately, I can't really do that now.
Probably can't, no. But then I've also had, you know, from my experience, you know, young people that I've been working alongside who have sent straight to their GP, and you know, the GP will ring me and say, why are you sending them now? I was like, because they need to be seen now. And I think it's that, just you have to be quite forceful, which I think can be really hard from a caring perspective, can't it? Lots of things to think about there. I'm going to pause it there because we're going to kind of move on to the next stage of the workshop with Kerry. But Paul, thank you so much for answering those questions. Really insightful and really useful information for us all to think about today.
You're welcome.
Well, Kerry, we are coming to this kind of penultimate section of the workshop. And I suppose we wanted to take this opportunity to really kind of ask your experience, not only from being a GP and maybe not knowing as much about eating disorders as you do now, possibly because of your experience, but then we're going to talk about the GP training as well that we're developing as the last part of this workshop. So I suppose, can we start with what's it like as a GP? You know, what was your first interaction with patients with eating disorders, and what training did you have?
So, I mean, I think obviously it was quite a long time ago when I did my training. I genuinely don't remember doing any eating disorder training as either a medical student or as a GP registrar. And even though I did a 6-month psychiatry placement, but I don't recall having any particular training on it at all. So I suppose I look back now and think, gosh, there must have been quite a lot of probably missed opportunities, I suspect, where people coming with lots of recurrent symptoms that maybe people had put down or might put down to other things. So, I mean, the first time I really would say I really felt like I gained a lot of knowledge, whereas I had a young boy, actually, sort of in his 13, 14, that his mum brought. He did lots of athletics, a very good runner, and she brought him because she was concerned. And it really took a good couple of times of them coming together for me to grasp, actually, do you know what, this is really serious. This isn't just he's doing a bit more. And he actually ended up having to be admitted because he'd become so poorly. And that was a real learning experience for me. So I sort of took that away and did quite a lot of research. I did it as a case study in my practice. So I felt that after that time, that me personally and hopefully our practice were a little bit more kind of keyed up in it. And we're hopefully then picking up some people and knowing some of the right questions to ask, I think. So that was probably where I was then. And then coming into it, I guess I feel like I had some knowledge, but obviously it was a very, very different ball game than when it was with someone, my own daughter. So.
And I think that's not unusual. A lot of people, carers that I talk to, quite a lot are in the helping professions. My mother was a nurse, and she didn't spot what was going on for me when I developed my eating disorder. So it's not so much about knowledge. It feels very different when it's your own child, doesn't it? How did that feel for you as a GP?
I think I've had quite a lot of people subsequently ask me and sort of say, how did that feel? Actually, I think I quite quickly just put to one side I was a GP in a way. I was basically like, we had a very, very steep learning curve, and I think I was just like, I'm going to be a mother first and foremost. And yes, it's very useful to have some GP training, but I would say to everyone we came into contact with, they were all like, oh, well, you're a GP, you'll know this. I'm like, no, I don't. Actually, just treat me like everyone else, and if I happen to know a bit more, that's great, but just assume that I'm at the same level as everyone else. And I think the people I worked with found that was quite useful, because actually I think they were then, otherwise they weren't sort of second guessing what I knew or didn't know. And yeah, of course, being a doctor did have some advantages, but I think I wanted to just be treated the same as everyone else. And of course it happens to everyone. So, some people are like, well, did you feel guilty? I was like, actually, I didn't, because I couldn't have changed it, I don't think. And therefore what I did or didn't know was kind of irrelevant. I probably picked it up quicker than I would have done, but there were still signs probably for several months before I was really, really onto it, I would say. So
yeah, no, I think that's really helpful to no matter what profession we come to this situation, whether that's a teacher or whatever, to come and say, actually, in this situation, I'm a mum, a dad, a partner, is really important. I think that's good learning for us there. So what were the first kind of signs and symptoms you did pick up on in your daughter?
Yeah, so I guess, my daughter, all of us have been a very active, sporty family. So, everyone out doing sport 3 or 4 times a week. And I think I just noticed over the summer when it kind of was happening that she was probably just doing a bit more sport. She looked like she'd lost a bit of weight, and she was starting to kind of be a bit more picky about her foods. All of us had always been people that just ate and ate and ate, although we were very naturally slim. But she was sort of starting to cut back on, sugary foods a little bit more, not wanting to maybe eat a bit of dairy. So kind of little signs. And I think I picked up on it and probably had the conversation and said, listen, if you're doing all this sport, we actually need to make sure we're eating plenty. And of course, got that sort of deceptively reassuring answer back that, oh, I'd not meant it to happen. And so probably was kind of, falsely reassured for another month or so, I would say. And then I think the real turning point was went away for, it was a friend's 50th, and there was a big group of us went camping. And we were near the coast, and she wanted to go running, and it was kind of getting towards kind of dusk. And I said, well, you can only go for 10 minutes because it's going to get dark. And she was like, yeah. And then basically disappeared for the next half an hour, by which point in time it was dark. And she came back and I said, this behavior is abnormal. This is not, I'm just going for a run. This is, I need to run for a certain. So that was the real turning point for me. That sort of really kind of clicked into, this isn't just being sporty. This is definitely abnormal behavior. And then spoke to the GP to get some blood tests, and then obviously arranged to go and see the GP.
So yeah, what was that consultation like when you went? Because I think we've talked a little bit, haven't we? Because we've been working together on the GP training. I'm guessing it was your family GP doctor that you'd known for a while.
Yeah, it wasn't a GP I particularly knew well, because I guess fundamentally I'd very rarely taken my kids to the GP because of course most minor things I've dealt with at home. So I think probably it wasn't someone I knew. It was an interesting one because I was going with pretty much thinking this is definitely an eating disorder. We'd done the blood test, I'd gone through the master plan guidelines myself, and she was definitely in the amber risk. Yeah. So I was sort of saying, listen, you know, I'm really concerned. I'm pretty sure this is an eating disorder. I'm pretty sure this is, you know, definitely in the moderate risk now. And it was interesting because the GP really didn't really know what to do with that. Even though they knew I was a GP, so you'd think maybe they might have been a bit more, okay, let's do that. You know, they did listen, you know, so they did listen to my daughter, and she kind of gave them the, oh, I didn't mean to, you know, I was just thought, you know, the same story I guess she'd given me, and actually kind of convinced the GP that everything was fine. And so I was then left in this sort of slightly bizarre scenario where, you know, the GP didn't do any measurements. There were nothing measured at all. So no real acknowledgement of the fact that we've been saying this, and I think this is, you know, on marzipan, I think this is an amber. So I kind of came out feeling quite wrong-footed, actually, because I was then thinking, oh, well, am I just being a fussy mum? You know, have I got this completely wrong? And it was on a Friday, and my daughter wanted to go to a netball tournament that weekend and was going away. And I then sort of felt a little bit like the wind taken from my sails. I couldn't say, well, you can't go, because actually this GP had said, we'll come back in a month's time. You know, so she'd kind of given the message, the GP had given the message to my daughter, well, I'm not worried. So then it was quite hard for us as parents to kind of really come down and say, and you know, she basically went away on this netball weekend and lost a kilo of weight in 2 days, and came back, and it was like, okay, this is a major issue. Took her back to the GP on that Monday. My husband took her, actually. She was referred and was seen that week. So it was a kind of odd scenario, but it makes me reflect quite a lot now on, you know, I was going to see that GP with medical knowledge, armed effectively with that marzipan guidelines, and yet it still wasn't really taken seriously. And I guess that's partly where my passion for GP training comes from now. And that's not a criticism of the GP, really. No. I think it was just, you know, this GP was probably quite a young GP at the time, and just really didn't quite know what to do with it, really. So
yeah, and I think for me, just hearing you say how much it wrong-footed you and how much authority that GP almost had in that family scenario for you, which then caused difficulty for that weekend, that boundary setting of your daughter going away for that netball weekend. I think a lot of carers and people listening will be quite relieved to hear even you as a GP felt wrong-footed by that, because, you know, that was someone kind of inputting into the situation. So I think that's what really kind of stood out for me. And then as your daughter got into specialist services, I'm guessing, what was the continued involvement with the GP during her treatment?
Yeah, I mean, I guess not very much, because actually she kind of fell off a cliff, actually. So, you know, she basically was seen by the eating disorder team, and the following week was admitted to hospital, and then went straight into a sort of specialist unit, because her weight loss was, she went from amber to red within a week. And so, interesting enough, not a huge amount of GP involvement at that point in time, because we were very much within the kind of the specialist team. But interesting enough, I did then, once things were a little bit more stable, I did then go back and speak to the practice initially, and said, listen, you know, this has happened. I'm not kind of complaining, but actually I really think you need to use this as a learning experience. And actually I know that they looked at it as a case review, and actually when I have subsequently, you know, since gone back and seen that particular GP, actually she's been, you know, we've been able to have a very good conversation about it. She just said, for me, that was such a steep learning curve. She said, you know, obviously she apologized, but she said, listen, I really didn't know what to do, and actually, you know, we did look at it as a practice. We really did learn from that. So you know, so actually we stayed with the same practice. I go back and see them. So from that point of view, I guess it was the same, like it's my experience I'd had 5 years previously. So I think it's more about how we make sure that GPs are in a position where they at least know what to do in the first instance, and I guess empower the carers so they do feel able to kind of go with quite a lot of, you have to be pretty firm, you know. I think the biggest thing I would say is trust your instincts as a carer, as a parent. Actually, if you think you know your child, your partner better than anyone else, if you think something's wrong, you're likely to be right, and you just have to go in a quite sort of firm and sort of manner, and just be quite insistent upon that. I think would be kind of a learning point from that.
Yeah, absolutely. You know, that's so helpful. And then I suppose, you know, we're going to cross the bridge now into looking at the training. Thank you so much for sharing your experience. I suppose, as a GP in that consultation, which I'm guessing can be 5-10 minutes, 20 minutes if it's a double appointment, I don't know, if you're lucky, but you probably know that there's people waiting. You know, what should GPs be asking? What are the main things? What are the top tips for GPs and for carers and using that time effectively?
Yeah, I mean, I think I'm going to switch it around and do the carers first, actually. So I think for the carers, really, it is being, actually, I'd sort of, write down your sort of evidence, I suppose, as much as anything. So you've got your sort of stories of sort of the abnormal behaviour and things like that. Actually, have a look at the marzipan guidelines. I mean, obviously for me, it was easier because I could do blood pressure and all those sorts of things. But equally, if you know that they've lost a certain amount of weight, go in with that information, or if they, lots of food's going from the cupboard, some of these sort of things that you're not sure if they're relevant. Actually, again, it's those pieces of the jigsaw, isn't it? If you bring them to the GP, hopefully the GP is going to be able to go, okay, this rings some bells for me, and I know that I need to do some more things. So I think go prepared, and I know the Beat have a brilliant letter, don't they, on the website?
Absolutely,
which is really good. And I think for the GPs, I think the biggest thing I would say is listen in the first instance, and that is hard, particularly only if you've only got 10 minutes. And I think even more so at the moment, it has been a really tricky time for all health professionals.
yes.
And I think, if you're starting off on the phones, but I think listen and really just be alert to the possibility of, could this be an eating disorder? Lots of sort of some sort of odd physical symptoms that maybe don't fit. Some carers will come in and say they've lost X, they've lost 3 kilos in the last month. You've got, and that should be ringing alarm bells. And that's the point where you go, right, okay, at which point do you know, okay, I need to be doing these marzipan today? Or actually, do I need to be just building up more of a relationship over the next couple of weeks to kind of get more of a picture? But I guess on that first consultation, you need to be getting a sense of, actually, is this person in a very high risk? In fact, do I need to be seeing them, if it's a phone consultation, am I switching this to face-to-face? And actually, I may end up having to send them to A&E today. And I think it's just that kind of variety of where you're trying to put them within that sort of framework, isn't it? And I think that's impossible to do if it's not face-to-face. And I think that's probably one of the biggest challenges at the moment, is actually, how do we make sure that some of these people that we know the numbers have gone up ridiculously, how do we make sure that these people that really need to be seen on that day are actually being seen on that day?
I think that's a really good point, Kerry. As a GP yourself, or you might have heard of others, are GPs having to hold patients with eating disorders a lot, in terms of waiting for specialist services to accept referrals or start treatment? What's it like as a GP at the minute, holding people?
So I mean, I guess, and again, if you think about this is only one small area of one branch of medicine of all the things. So I mean, this is unfortunately going across all areas. But in terms of eating disorders, and obviously I know this from both sides, working as a GP and now working within the eating disorder services, and the numbers have just gone through the roof. It is very difficult for everyone. It's very hard for carers. They've got the kind of, I guess, bravery to take their person with them, because probably that person's gone very reluctantly, I suspect. And yes, and hopefully the GP is doing the kind of thinking, okay, yep, okay, I know I need to refer you. They're doing the kind of referral forms. And the tricky part then is obviously the eating disorder services are all so overwhelmed that actually, in lots of cases, they are, there's long waiting lists. We're talking 3-4 months before they can see people, depending on what their risk is, but so, that's a really difficult scenario for everyone involved. So it's difficult for the carer and for the sufferer. The GPs are then, some GPs I know are holding these patients, some of them aren't. And then obviously the eating disorder services I know are feeling terrible that they're not seeing these people that need to be seen. So this is very, very difficult scenario. I know Beat are doing an amazing job of trying to get lots of additional support in for the carers, for people in that scenario. But there are no quick, easy fixes. And I think that's the real problem. It's not like we can suddenly, get more and more people up. I think if we can upskill GPs so they feel a bit more confident to hold some of these patients, I think that certainly is a good start. And I know a lot of the eating disorder services are trying to expand their work teams to sort of be able to cope with this. And sort of, new ways of working. I mean, lots of medical monitoring clinics are coming up where people are being medically monitored. I say simply, I think medical monitoring isn't just about looking at the parameters. I think it's about giving the carers focus. I think it's about, that's a point of contact. So I think it kind of works in lots of different ways. But I think it's just a very hard scenario at the moment.
It is, it really is. And I think, we're not about bashing GPs. I think the reality is that you have to know so much, don't you, and be able to cover all your bases. But I think it's also knowing how we can support GPs to feel more confident. I think that's the phrase that you said, in using that time, knowing what they're doing, which moves us nicely onto the training package. So we won't give too many spoilers, because obviously it will be coming out soon. However, we just wanted to outline today that Health Education England have commissioned Beat to write the training for GPs and for the medical monitoring, which I know, Kerry, you're hugely instrumental in helping us write at the minute. Can you give us a few a few clues on what's going to be in there?
Sure. So the GP training is, I mean, a lot of it is about almost bringing together what existing resources. So, I mean, there are lots of good resources out there already on the RCGP website, on the e-learning for health. Lots of individual sort of training schemes have their own really good resources. So from the start, we said we didn't want to reinvent the wheel. We really just wanted to bring together, the best of those resources in one place so people knew where to look. And so some of it's about bringing that together. Some of it's about making it kind of interactive. So, none of us particularly like sort of sitting through an hour of, just being told something. So we're very keen to put some case studies in there to make sure that people, I know I learn best. And I think most people will say they learn best if they can kind of really attach it to something that they can kind of, and actually quite often with a case study, it'll remind you of someone you think, oh, okay. So using that. And just really within the training, then embedding some kind of really useful leaflets that people can give. So for instance, GPs can give out to carers while they are on the waiting list, and some top tips. So trying to have a sort of one resource in one place, but that's got links to if people want to do further kind of information or further training. And it's how you get all of that into one sort of small package.
Absolutely, it's a real challenge. But I think, going back to something that Paul said, is that, people with eating disorders don't necessarily present in a way you'd expect, I think, as a health professional. They don't necessarily ask for help, do they? And I think that's what we're trying to get across, isn't it, in the training, is like, the signs and symptoms you can look out for medically, but also those communication skills. What are they not saying, and what do you need to ask? So I think, I know that we'll have lots of lived experience threads throughout the training as well, to kind of get across what it, so that people understand what it feels like to suffer with an eating disorder. And I'm super excited to see it.
And I think it's particularly more so maybe more in adults than children, because generally I suppose a child will be brought by a parent, and a parent will be giving you quite a lot of that story, whereas obviously quite often an adult might be someone that is, I guess it's highlighting to GPs in particular, some of those patients that kind of come with lots of different kind of symptoms that don't seem to be linked at all. Actually, could it be that there's something else beyond that? And as you say, it's knowing those questions to ask in that scenario. That, if you've just at least thought, oh, okay, could it be this? That some of those kind of, I guess, almost screening questions that you can then ask to kind of think, yes, it is, or it could be, or no, I'm pretty sure it's not, and just sort of put you on those pathways and just give people the resources. I mean, we're not expecting GPs to be experts, because as you say, we are generalists. It's what we are good at, sort of looking at the whole general picture. But when you start to look at something, it's then recognizing, okay, I'm not sure, therefore actually I need to refer. And that's a kind of one of the key messages as well, is about actually think about it as a possibility. If you've then thought about it, actually then refer on. And I know we've talked about constraints within the system, but that's not a reason not to refer, because all the systems are different nationwide, and lots of people are trying lots of inventive ways to kind of deal with that. So it's not a reason not to refer if you think, well, they're not going to be seen. Actually, it's really, really important to still make that referral.
Really helpful. Kerry, thank you so much for taking the time to join us today. I know that we'll be around and available to answer questions throughout the conference, because I'm sure there'll be people sat there thinking, oh, I wish I could have asked them that. Well, the good news is you can. We'll try and be around to answer questions on the chat function for the conference, but hopefully maybe pop up in one of the networking lounges too. But yes, Kerry, thanks so much for your input today and for all you're doing to support Beat.
Pleasure. Thank you.